Hi everyone, welcome to the fourth episode of the Dysmenorrhea Project podcast, Beyond the Bias. My name is Sangavi.
I'm Jacqueline. We're two medical students who are passionate about women's health and want to take you all with us on our journey to learn more about this underrated side of medicine. In today's episode, we will be discussing implicit biases, specifically those related to gender, and how they affect patient care. We also have our wonderful guest, Imogen, the founder of Stories of Us, a platform that aims to shine a light on individuals who have symptoms that have been unrecognized due to medical bias.
So what is implicit bias? Implicit bias is the unconscious association between a group and a particular attribute. These may be based on race, income, literacy, age, or gender. Throughout history, the healthcare system has been designed by men for men, and therefore gender bias in medicine can be traced back as far as the ancient Greeks, where the term hysteria, based on the Greek word hysterikos, meaning of the womb, eventually became a catch-all diagnosis for health complaints made largely by women, including things ranging from menopause to anxiety and depression. This male as default approach has dominated every aspect of healthcare, from the clinical trial stage through medical training and to healthcare services and policies. This has resulted in insufficient information about women-specific conditions, including but certainly not limited to menopause and endometriosis. But it is not just women-specific conditions that are under-researched. It also includes diseases that affect both sexes, such as cardiovascular disease or mental health disorders, with limited research on how they may present differently in either sex.
Further highlighted in the 2022 Women's Health Strategy, a 10-year plan to improve women's health in order to address the health disparity between men and women. This study was the first of its kind in England and received approximately around 100,000 responses from women across the country. It revealed that 84% of the respondents felt their voices were not being listened to. This not being listened to appeared at all stages of their healthcare journey, including their symptoms not being taken seriously, sort of like being dismissed on the first contact, and often coupled with an explanation that certain symptoms should be accepted as part of being a woman. And also the second thing is the need to persistently advocate for themselves to secure a diagnosis. Thirdly is the limited opportunities to discuss treatments and ignorance of their personal preferences, including gender stereotypes of what a woman should want, especially in relationship to having children, and this being used to deny options. And this health gap does not affect all women equally. Those from disadvantaged ethnic minority groups are more likely to report that they do not feel listened to. Now we're down to the interview section of our podcast. So we have Imogen, who's going to be our guest speaker for today. So could you introduce yourself more to our audience and talk us through your background?
Yeah, for sure. Thanks so much for having me. So as you said, my name's Imogen. I'm a third-year medical student at Barts. And before I was a medical student, I worked as a journalist. And when I was working, I kind of came across a lot of these issues in terms of medical bias and health. And unfortunately, I've also experienced those issues myself in my own medical care. So I decided to launch a project looking at these issues, and it's called the Stories of Us, which is why I'm here, I think, to talk partly about that and also to talk about the other kind of areas of medical bias that people can come up against.
So at the start of our podcast, we discussed how gender biases can affect women's healthcare outcomes. So Imogen, what have you found since starting your website, Stories of Us? How do you think medical bias affects women's healthcare experience and outcomes?
Sadly, as I'm sure you guys have already been speaking about, it's pretty pervasive. I think it's really frustrating that in this day and age, it's still something that people are experiencing constantly. I mean, I'm sure all of us have friends that have experienced it, if not having experienced ourselves. I think it's one of those things where so many women have been told, don't worry about it, you know, this is just what happens, this is normal, take some paracetamol, go home, your pain isn't that bad, those kind of things, that we almost now reinforce it with each other. And I'm not blaming women for that. That's not the case. It shouldn't be happening. But I think I've been in the position where I've kind of said, well, you know, this is what happened to me, so maybe that's what happens to everyone. And I think it's one of those things where it's time that we need to actually stand up and say, this isn't okay. We won't accept this treatment from GPs, from doctors. If doctors tell us that our pain is in our heads, that's not medically acceptable, in the same way that it wouldn't be medically acceptable if a man was told that. And I think men, have a history of advocating for themselves in a way that is accepted, whereas women, when we try to advocate for ourselves, it's often not accepted because we see it's hysterical or aggressive. And all of these things, there are so many causes, there are so many issues around them, and there's so many different areas that we need to kind of tackle those issues from. And I think that's part of what I've been seeing with my project, is that people are saying, how can we advocate for ourselves in a better way? How can we actually change the system from the ground up, or change teaching, things like that, rather than just being stuck in this position where we're constantly having to tell people that they're wrong. It becomes very difficult, very taxing.
So what do you think about implicit biases affecting sort of women's outcomes for diagnosis or treatment wise?
Yeah, I mean, the statistics are really, really upsetting still. I think it's really shocking that it's still happening. There are so many studies and so many stories of people where, women are so much less likely to get diagnosed with heart attacks, to get diagnosed with various types of cancer, to get diagnosed with all kinds of IBS, celiac, even things like dementia and schizophrenia, all of these things. There's almost nowhere where there isn't some kind of problem with women's diagnosis, right? And I think what's really hard is that a lot of doctors and healthcare professionals don't intend to misdiagnose, but as you say, it's an implicit bias where they haven't, for example, seen conditions during their teaching on women's bodies or from women's perspectives. They haven't been made aware of these statistics that, for example, women are 22 times less likely to get a referral for knee surgery if they have knee pain, right? So if they don't know that, then they might not even be aware that their biases are causing them to say, oh, you're in pain, have some sedatives, have some painkillers, whereas to a man with the same condition, they'd say, oh, we need to refer you to the orthopedic surgeons. And so I think it's not that I want to necessarily say that someone or some group of doctors, some group of medical professionals are intending to cause this outcome. It's more that we're all implicit in this problem. We're all contributing to it because we're not getting the training and the teaching that we deserve to have.
So because you've already started a project regarding medical biases, have you come across any people for example some certain conditions that are more likely to be misdiagnosed because of this bias, or do you know any sort of situations that are common occurrences?
Yeah, I mean, unfortunately, I have stories myself. I know of many people that have stories. I think one of the most common conditions that comes up is endometriosis. That's one of those conditions that currently takes, I think, 8 years on average to get diagnosed, even though for many women it causes completely debilitating pain, job ending, life ending pain where they can't even leave their bed. I have a friend who was in that position. It took her about 7 years to finally be referred for surgery. And I have, so many friends that have these issues with periods, where because we, I think, have kind of accepted that a level of period pain is normal, but we haven't quantified what pain means. Yeah. We have people who have, to take a few paracetamol once a month on the same level as people that cannot leave their bed because it's a 10 out of 10 pain that they need surgery for. And those things are almost being treated as if they're on a similar level because this idea of quantifying isn't really there. And I think a lot of women, when they talk about their pain, the instant reaction from professionals is that they're over-egging it, they're a bit hysterical, these legacies that still follow us around. People wouldn't necessarily use the word hysterical anymore, but it's definitely a perception that people have. And there's lots of other stories that I've heard, especially to do with things like mental health conditions and ADHD. So quite similar actually to heart attacks. ADHD presents very differently in women to in men, and the male presentation has been kind of understood to be the norm. So with heart attacks, as we know, then this norm is kind of this crushing pain radiating down the left side. That's not something that a lot of women will experience, and that means that a lot of women will die. Many more women will die from heart attacks or will not be referred appropriately because people don't know what they're looking for. And with ADHD as well, you have this phenomenon where women's ADHD will often present almost entirely differently to male ADHD, because women have a lot of coping strategies often to mitigate it, because they're expected to be the planners, the organizers, so they kind of have all these strategies that they build so that their forgetfulness doesn't impact their lives too much. And women are also more likely to, for example, daydream or be inattentive, whereas men, boys especially, are more likely to be seen as, hyperactive and running around. And it's these kind of gender segregation things that make it much harder for people to actually be referred, especially when they don't know what ADHD is. Women are often having to go off and then do their own research to see, do my symptoms fit within any pattern? Whereas for men, it's more common that they'll show up, they'll present their symptoms, and the doctor will be able to say, yes, I know what this is, because that's how they've learned to diagnose that condition.
Yeah.
Which is very frustrating.
So you've already mentioned quite a few of the factors you believe are contributing to the disparity, so including women being seen as hysterical sometimes, or not being believed for their pain, and just the very definition of pain that can be different for men and women, and what people perceive as pain in women versus men. But do you think that you've obviously mentioned that women come up with coping strategies sometimes just because their pain is ignored and they have to come up with other things to deal with. Obviously, it's not the same for every woman, because some women are more educated and they're more willing to want to advocate for themselves, and they have more support to be able to advocate for themselves. So do you think there are any other factors that you think contribute to this disparity beyond just pain, hysteria, and things like that?
Yeah, definitely. I think, as you say, advocacy is a problem. I think there's this kind of pattern where a lot of men who come to the doctor came because their wives or their partners, female partners, forced them to go and kind of nagged them about it and said, you have to go, you obviously have something wrong with you. Whereas women who present to the doctor will very rarely come with that story. It'll be much more of a situation where, they realized that something was going on and they put it off because they didn't want to bother anyone and they didn't want to annoy anyone, and then they finally present. So there's definitely a massive socialization of women to kind of be quiet and act like nothing's wrong and kind of push through. And I think that's a problem that it's hard to say there's a simple solution, because I wish every woman would just stand up and advocate for themselves and be able to throw all that in the bin. But it's very difficult when a lot of women do have much more caring responsibilities than men. They do have a lot more burdens and daily things that they have to do that they can't just walk away from. And I think education is a big part of that. I think there's been really great educational campaigns, urging people to go get their symptoms checked out. I think when that becomes more of a public facing thing, it becomes harder for people to kind of ignore and hide behind their responsibilities and say, I have too much to do, because hopefully friends and family will also be pushing them to go and get checked, and will be maybe taking some of those responsibilities off so that they can go. But it's really hard. I don't think there's a simple solution. I think for me, the kind of solution that I see as more impactful is actually from the other end, so from the medical side. So there's been some really interesting studies with actually in the US with psychiatric symptoms, and also I think in Denmark as well, where basically they've introduced some kind of checklist, which is like this automated checklist that obviously doctors have for many different things. They've introduced them for specifically conditions where there's a massive gender disparity in treatment, so heart attacks being an example. They found that when you introduce these kind of checklists that force people to go through these options, could it be this, could it be that, when someone comes in, it almost eliminates the gender disparity in lots of different contexts. So this was also done with the disparities in Black and white people being treated for schizophrenia. They found that when those checklists were added, so many Black people this was in Illinois in the US, were being admitted, hospitalized for schizophrenia, when the white patients weren't, because they were just sent off home. And that disparity was very much reduced when these checklists were introduced. So I think checklists and these kind of monitoring systems are really, really helpful in this situation. But I also think, the more that we can advocate for ourselves, the more that we as women can push other women to go and get things checked out, and not when people say, oh, it's probably fine, say, yeah, probably is fine, but you should go anyway. Those kind of things, I think, are going to be really helpful going forward.
So just to summarize in terms of action plans for the NHS really and the UK-based sort of clinical practice, how do you think sort of policy change or anything that can change healthcare professionals perspective towards this gender bias?
Yeah, I think we need better education at the student level. So for all professionals, we need bias training. It's not always the most effective, and a lot of people, won't take it seriously. But I think that's the first step to integrate that into, formal training, to make sure that it's as much part of training as learning about conditions is. I think another step is these kind of checklists, these automated systems that, again, kind of integrate it into the fabric of the daily job, the daily work that we do as medics, so that it's not something that can be ignored. I think patient advocacy services are really important, encouraging people to reach out to them, encouraging people to, for example, bring a chaperone if you feel like you've been ignored by doctors one too many times. If you have a doctor that's particularly rubbish, advocate for getting a better one, advocate for a female doctor if that's, what you think will help. And yeah, I think also training more, having schemes to train more doctors who are women, who are people of colour, who are people of marginalised identities. I think those things are so super important as well, because, if a woman comes to me as a doctor and says, I can't get out of bed in the morning because of my pain, I know what that feels like. I'm not going to say, oh, I'm sure you should just take more ibuprofen, which, maybe that is what you would genuinely think if you had never experienced that. I don't know. But I think having as many women as possible in these kind of professions, and as many people who have, obviously this is an intersectional issue, right? It's not just women, it's women of colour and trans women and women who are queer. Like, all of these issues intersect and make it harder and harder and harder for people to get taken seriously. And so I think the more people that we have who belong to those identities and who can advocate for their patients, that's the most important thing, I think, for me.
Thank you so much for your interview today. We've learned a lot, and yeah, hopefully our audience gained a lot of insight from this. Thank you.
Thank you so much. Cheers.
Up next is our section on beating misconceptions, where we'll be debunking some common myths on gender bias in healthcare. Number 1. Gender biases are a problem of the past.
2008 study in America on the gender disparity in analgesic treatment of acute abdominal pain in the emergency department revealed that women were 9% less likely than men to receive opioid analgesia. Women who did receive analgesic wait on average 16 minutes longer than men. Similarly, a 2022 audit in Australia of the gender-based differences in management of acute abdominal pain in the emergency department again revealed similar findings, including men being more likely to receive combination opioid and non-opioid analgesia. Women were more likely to wait 90 minutes before receiving analgesia, and women waited almost twice as long for follow-up analgesia. And these are just 2 studies focusing on a very specific healthcare pathway, analgesic treatments of abdominal pain. Unfortunately, gender bias continues to be pervasive throughout healthcare systems, and so saying it's a problem of the past is not true.
Number 2, heart disease is a man's condition, so women don't need to worry about it as much.
According to the British Heart Foundation, coronary heart disease, the main cause of heart attacks, was the single biggest killer of women worldwide in 2019, and kills more than twice as many women as breast cancer in the UK every year. Despite these staggering statistics, a woman is 50% more likely than a man to receive the wrong initial diagnosis for a heart attack. They're also less likely to receive potentially life-saving treatments in a timely manner, and less likely to be prescribed medications after the heart attack to prevent a second reoccurrence. Interestingly, a 2019 study found that the assumption that women have different symptoms during a heart attack is often incorrect and can result in misdiagnosis and delayed treatment in women. This was estimated to have contributed to at least 8,200 avoidable deaths in England and Wales in the last decade. Therefore, it's important that we're all aware of the common symptoms of heart attacks. These most common symptoms in both men and women include chest pain, with women more likely to have pain radiating to the jaw or the back, and women also being more likely to experience nausea in addition to the chest pain.
Number 3, women are more emotional, so their medical complaints are often over-exaggerated or psychosomatic.
Women are greatly overrepresented among patients with chronic pain. They are more likely to suffer from chronic pain syndromes such as fibromyalgia, osteoarthritis, and migraine headaches, as well as conditions specific to women such as endometriosis and dysmenorrhea. They are also more likely to suffer from more than one condition, with a sample of 100 million Americans with multiple chronic conditions finding that 54% of them were women. However, is this because they are more emotional and exaggerate their symptoms? Not necessarily. Studies on pain vary in their results as to whether there are noticeable sex differences in pain sensitivity. However, there are difficulties in assessing pain, excluding biases that may occur due to subject-experimenter interactions, and also the complications of menstrual cycles affecting pain tolerance. However, when differences have been observed, they are almost unanimously showing that women have a higher sensitivity and lower tolerance to pain. A 2021 research study involving lay participants having to watch a brief video clip of real patients undergoing painful examinations, with extra information being given about the patient's ratings of their own pain, had some interesting observations. They showed that these lay observers, when asked to record the patient's sex and estimate their pain on a numerical scale, revealed that when compared to the patient's own score, observers of either sex consistently underestimated women's pain and overestimated men's pain. And when women and men showed exactly the same amount of pain in their facial expression, women were still thought to be in less pain than men. So it's definitely more than just women being just emotional or exaggerating, but a combination of women often presenting more with chronic pain conditions and also just being perceived as exaggerating by men and females in the community.
And that's a wrap for this episode by the Dysmenorrhea Project.
We've learned lots about medical biases, and hopefully this has increased your understanding and debunked any misconceptions relating to this interesting concept. The sources used in this episode and links for further reading are listed in the description below.
Please make sure to like and subscribe to our channel and follow our Instagram page for more future content regarding women's health topics. Looking forward to seeing you in our next episode.